Welcome back. In this video, we'll mention all clinical reflexes, the physiology of reflexes, and the causes of hypo and hyperreflexia. Reflexes are caused by a closed loop of nerve-muscle connection. Whenever a muscle is stretched or tapped, a nerve signal is sent all the way to the spine, and then a returning signal from the spine will command the muscle to contract. All of this occurs without even the brain knowing this happened. And only after the contraction occurs does the brain know that the contraction actually happened. So reflexes are possible in patients even without a brain. Let's start from the feet and make our way up. The first reflex we have is the plantar reflex. This is also known as the Babinski sign. If you stroke down the sole of the foot, the normal reaction is that the patient will contract their toes. In cases with upper motor neuronal damage, the patient will extend their toes instead. This is called a positive Babinski sign. The nerve responsible for sending the signal to the spinal cord is the L5 and S1 nerve, and the efferent nerve, the one coming back, is also L5 and S1. Like we said, plantar reflexes are important for the function of upper motor neurons. This is the normal plantar reflex. As you can see, there is toes flexion. And this is a positive Babinski sign, where the toes extend instead of flex. Just above the plantar reflex, we have the ankle jerk reflex, and it is caused by the contraction of the gastrocnemius muscle. The nerves sending the signal to and from the spine are the S1 and S2 nerves. In cases of disc hernia that compresses the L5 to S1 nerve, we don't see this reflex. This is ankle clonus. As you can see, after manipulating the foot and then pushing it forward, there's a clonus or a jerk in the foot. Patellar reflex or knee jerk is very important in the clinical practice because even small changes are easily detectable. The nerves responsible are the L2, L3, and L4. And this is how to perform the patellar reflex. Triceps muscle reflex is more prominent in patients with hyperthyroidism. The nerves are C6, C7, and C8. And this is how to perform the triceps reflex. Biceps reflex are performed by C5 and C6. And this is how to perform the biceps reflex. The cremasteric muscle reflex is very important to differentiate between testicular torsion and scrotal skin conditions and infections. It is carried out by the L1 and L2 nerves. This is very important in the clinical practice and also in the exams. Hyperreflexia is basically exaggerated response to mild stimuli. So even if you tap the muscle lightly, there will be very strong reflex. We see this in the case of stimulants use, hyperthyroidism, serotonin syndrome, multiple sclerosis, Reye syndrome, which is caused by aspirin use in patients with viral fever-induced infections, and preeclampsia. And we see it in patients taking depressants, hypothyroidism, excess magnesium, which is important in exams, Guillain-Barré syndrome, Lambert-Eaton syndrome, and Friedreich's ataxia. There's another condition which is called areflexia, which is basically complete absence of reflexes, and this is commonly confused with hyporeflexia. So hyporeflexia is having mild or small reflexes, and areflexia is having no reflexes at all. The primitive reflexes are seen in pediatrics, and they're so deep and branching that they deserve a video of their own. They're not really all that important for your exam, so I decided not to mention them here. And here's a small quiz. What is the nerve supplying the following reflexes? And here are the answers. Alright guys, that's all I have. Thank you so much for watching, and hopefully this helps.